Hello, everybody, and welcome to today's live stream. Today we are hosting Dr. Thor Halfdanarson. I am your host, Mike Wayman, of course, from NCAN. Before we get into the live stream, I do want to remind everybody some really important things going on in the world of NCAN. We have our virtual walk, which is going to be happening starting October 1st. Please make sure you register by October 1st so you can get one of these fine t-shirts here with the nice little 20 years of service. It's your opportunity to show your stripes. So also, when you do sign up, make sure that you tag us at Net Cancer Aware on all the social medias, so this way we could share it, we could show how you guys are showing your stripes. And also in October we have the Miami Patient Conference. It's happening October 14th, happening in Miami, Florida. We've got a really great lineup, a really full lineup of doctors and panels. It's going to be great. Charlotte, North Carolina, we have our physical Strides for Stripes on November 4th. And last but not least, we have our gala on November 11th. It's our 20th anniversary of doing this. It's going to be huge. We're going to have some great doctors there. We're going to have some great awards to give out and some crazy prizes. There's probably close to like 200 baskets that we've seen, and usually the day of we get a lot more, so it'll be a great time. So you can get all the info on all those great events at netcancerawareness.org, and of course on all of our social medias at netcanceraware. So without further ado, I want to welcome everybody to the Q&A. We have Dr. Thor Halfdanarson here. Dr. Thor, how are you, sir?
I am well, thank you.
So basically the way we're going to work this is, if everybody wants to participate, please feel free to text the number scrolling down on the bottom of the screen, 516-584-4576. And you can also, in the comments here on YouTube, we'll try and field through those. So, Dr. Thor, how are you, sir?
I'm doing very well, thank you.
Yeah, thank you so much for joining us. We're excited to have you, and we're gonna kick things off with sort of the basics. Can you please let everybody know a little bit about yourself and your background, what got you into nets?
Sure. So, pardon me, I have a little bit of a cold, so my voice is a little raspy. So I'm a medical oncologist. So I'm actually originally from Iceland, where I did my medical school. So then I did my residency in internal medicine at the University of Iowa. That's where I got to know the Autoresio, so Tom and Sue Autoresio. And I think that's probably where this all started. And then I went on to do my hematology and oncology training at Mayo in Rochester. And then that's where I really got into neuroendocrine tumors, initially with doing research on pancreatic neuroendocrine tumors. And then after I graduated from that fellowship program, I went back to the University of Iowa, where I was on staff, on faculty for 5 years, in really helping to build that NET program, which already was very established when I got there.
Right.
But the medical oncology part was not as established as the surgery and endocrinology. And then in 2012, I went back to Mayo, initially to Mayo, Arizona. And then I've been at Mayo in Minnesota for the last 7 or 8 years now.
Great. So I'm guessing when you went to Iowa, the Autoresios kind of sucked you into the net space.
They certainly did. They are really good at that. It's just very hard not to get. It was just infectious enthusiasm for improving net care. So it was impossible not to get sucked into it.
Yeah. I mean, you'd be hard pressed to find somebody as enthusiastic as Thomas Autoresio was about
Absolutely.
nets. So yeah, absolutely. So real quick, for any of the new people who are joining us, can you just give us a little bit of a description about what net cancer is, and describe like NENs versus nets?
Sure, absolutely. So, excuse me. So neuroendocrine neoplasms, or some we sometimes call NENs, it's a group of cancers that can really start anywhere in the body, and they are mostly what's called the neuroendocrine tumors, which are slowly growing or relatively slowly growing tumors. And they can start, as I said, almost anywhere, but most commonly in the small bowel, pancreas, lungs, in the rectum, and in the stomach. And interestingly, these are getting a lot more common. If you look really at the numbers in the US for the pancreatic neuron tumors, we've seen about threefold increase in the number of new cases per year in the last 15 or 20 years. And I think it's mostly just we're getting much better at diagnosing this, but they might actually be becoming more common. So just recently, there were studies, similar studies from England, showing that the neuron tumors had really increased there as well. And now the prevalence of neuron tumors, that is the number of patients actually living with neuron tumors or having been diagnosed with neuron tumors, the prevalence of neuroendocrine tumors in England is now the 10th highest cancer. So this is not a rare cancer anymore. And if you just look at the sort of abdominal or the digestive cancers, neuron tumors are now the second most common digestive cancer after the very, very common colon cancer. So this is essentially saying that in terms of patients living with this, it's more common than pancreatic adenocarcinoma, it's more common than stomach cancer, more common than esophageal cancer. So this is not a trivial issue anymore. And that's what we're trying to do, is to raise awareness of this and say we can't really ignore this in terms of getting more research funding and getting more like greater allocation for clinical care, because we have so many patients with neuron tumors. So with the neuron tumors, they are very, very sort of different from one person to the next. They can be extremely slow growing. We have people with neuron tumors that have been metastasized for like 10 or 15 years, and we haven't really done anything for it yet. I have one patient who's had metastatic neuron tumor for at least 10 years now, and he's never seen any therapy because he's growing so slow. And then we have others where the tumors are much faster growing and they need treatment within weeks or even within months. So extremely different from one person to the next. I keep telling my patients that there are really no two neuroendocrine tumor patients the same. So everyone is a little different from the next person with a neuroendocrine tumor. But getting more common, we have a lot more treatments for them. I have never been as optimistic for neuroendocrine tumor patient care as I am now, because we're getting a lot of new things.
Yeah.
So hopefully that was
Yeah, no, that was a great overview. Just real quick, for anybody who did text something in for the first 5 minutes, please resend it, because we had to do a couple of technical things here in the background. But we do have some questions here coming from the audience. First one here I have is, what is the treatment for someone with primary and mets of the lung if you don't have receptors?
Great question. So, if you have a lung neuron tumor without what's called somatostatin receptors, so these are tumors that don't light up on the gallium or copper dotatate PET. So then we have a few options. So if it is a localized tumor, let's say uh, localized to the lung and maybe a few tumors in the liver, then we can sometimes do surgery and we can do radiation treatment and what's called ablation therapy. And we can just treat the tumors where we can see them. But for more advanced tumors where we can't really do surgery, can't really do radiation treatment or ablation, then we have to think about drug therapy. And now, if they don't light up on the dotatate PET, that means that they don't have the target for the somatostatin receptors or somatostatin receptor drugs like octreotide and lanreotide, and they don't have the target for PRRT. So that leaves us with a somewhat limited options, and everolimus or Afinitor is the only FDA-approved drug for that indication. But there are others that work. So the combination of capecitabine and temozolomide, also known as CAPTEM, that can sometimes work really well. And we're getting really excited about some of the newer drugs like cabozantinib and lenvatinib, which are what's called the tyrosine kinase inhibitors or targeted drugs. They might actually work as well. There are some IV chemotherapies that can work too, but we try to sort of stay away from them as long as we can, unless the tumors are really aggressive, because they tend to have more side effects and be generally harder on people. And we hope to get more treatments for these neuroendocrine tumors of the lung as we understand the biology a little better.
Great, great. Dr. Thor, real quick, would you mind just lowering the volume on your computer just a tad?
Sure.
Okay. So yeah, next question is why doesn't my duodenum net show up on a dotatate scan?
So there are two reasons for that. So one of the reasons is that maybe it just does not have the somatostatin receptors on the surface of the tumor cells, or it doesn't have them in enough quantities. If they're just scattered like one here and one there, then it's just not enough to light up on the dotatate pattern. It could be that you don't have the tumor doesn't have any tumors at all. And also, if the tumor is really small, and we say that if the tumor is less than 10 millimeters, which is about a third of an inch, then they may not reliably show up. So it could be either a function of the tumors just being too small, or the tumors just not having the somatostatin receptors. So those would be the two main causes.
Okay, perfect. Uh, is there a difference in accuracy of the 5-HIAA urine or blood test? I'm wondering
Great question. So
if there's a significant cost between the two.
in terms of performance, I think all of the studies that have been published, and some of them haven't been published yet, just been presented. So all of them suggest the same. There's no performance difference. So if they really strongly correlate with each other, the advantage of doing the blood is that all you need is just a like an 8-hour fast. We like our patients to stay away from certain foods when they collect the urine, so like bananas and plums and nuts and some other things. And because that can falsely elevate the numbers. And we like to have patients stay away from that maybe for a day or two before the blood test, but it's probably not necessary. So equally good tests, but with the blood test, fasting blood test in the morning, no lugging the jug around with the urine, so just so much easier. And for example, at Mayo, we now have this test available at Mayo, and we run this 3 times a week. So sometimes I see patients in the afternoon, let's say on a Wednesday afternoon, and they came in that morning and turned in the test, and they have the results available.
Perfect. That's great. Something that we cover a lot here on on these live streams, and then also on the podcast Nets Get Real on our YouTube and all streaming platforms, is huge question. Why should patients seek out a net specialist, and what is the importance of a multidisciplinary team?
Great question. So, why should you seek out a specialist? So, the thing is that, and this has been shown in studies in Europe, is that when you go and you see a neuroendocrine tumor specialist, it's not the necessarily that person you're seeing who is the most or the only important person. It's everything else. It's a pathologist who looks at the specimen. It's the radiologist who looks at the scans. It's the gastroenterologist or who else is involved. So we know from Europe that that if you go and you seek a second opinion at a neuroendocrine expert center, the diagnosis may be changed in up to a quarter of cases. So that is sometimes as simple as just changing the tumor grade a little bit, sometimes just changing the diagnosis. So we have had patients referred to us with neuroendocrine tumors who didn't really have a neuroendocrine tumor, they had a different cancer. And then we have also had patients referred to us with, let's say, pancreatic adenocarcinoma or bile duct cancer that turned out to be a neuroendocrine tumor. So it's really probably the most important thing with the second opinion is just to get the right team of people who do this day in, day out. An oncologist or an endocrinologist who works with pathologists who are experts in pancreatic or in neuroendocrine tumors, not pancreatic, and they can correctly interpret the biopsies. So that would be one thing. Number two is that we because this is what we do all day. We do this all, like I'm in clinic every day of the week. And so I see neuroendocrine patients every day. So I have access to clinical trials. I really keep a good tab on the literature. I don't have to keep up to date on lung cancer and breast cancer and bladder cancer and prostate cancer. So I can really devote my time to the neuroendocrine tumors and really keep an eye on the literature. So I'd like to think that I'm a little bit more aware of the options that are available for patients with neuroendocrine tumors, because this is all I do. And as for the tumor board is incredibly important. So tumor board not every patient needs to be taken to tumor board. But if you have a decision where, let's say someone comes in and we have the option of medical therapy or maybe surgery or radiation or just watching, and we don't really know what's the sequence, where should we start, who should go first, things like that. That's where tumor board becomes really invaluable. So the way this works at Mayo and other places is that we present the case at the tumor board, that we look at the scans together, everyone gets to weigh in, and then as a group, we come up with what we think is a good plan. And I will tell my patients, so this is very important. So I will see the patients in the clinic and I say, I have a really great plan for you. But I'm going to take your case to tumor board and my plan may get shot down. So sometimes even what I think is a great plan gets changed when I take it to tumor board, because now the surgeons say, well, didn't you really think about that tumor close to that blood vessel? And the radiologist say, didn't you really see that tumor there? And these are the things that happen at tumor board. So I may call or reach out to the patient again and say, remember the plan I told you about? Actually, I think we have a different plan. And so that's that is really the value of the tumor board, just getting more brain power in the room on a case, but it doesn't have to happen every time.
Right. Okay, next question here. We got a lot rolling in. So, are there clinical studies on Zermello that have been completed recently?
So there are some studies on Zermello ongoing. So there is a study of Zermello with PRRT. There is a study on Zermello for patients at risk of carcinoid heart disease. There is, or maybe I don't think it has started yet, a study of Zermello on patients who are going to the operating room to prevent the carcinoid crisis. So I think all of these are still ongoing. So the completed Zermello studies have mostly focused on diarrhea, the management of diarrhea. And that's where I think Zermello really has the greatest potential. So I will say this, that I think the initial Zermello studies were not, in retrospect, probably not as well done as they should have been done, because I think a lot of patients on those studies may have had other causes of diarrhea, like bile acid diarrhea or something else. And the Zermello in those studies was not shown to be all that effective. And yes, it helps some patients, but if you have carefully excluded other causes of diarrhea, and keep in mind there are many, many causes of diarrhea in patients with neuroendocrine tumors, and if you excluded other causes and now you're left with carcinoid syndrome diarrhea driven by high serotonin, I actually think Zermello is a really effective drug. So I think actually Zermello is for carefully selected patients. I think it's a really good drug.
Great. I just wanted to put this up here. Ruth Hawks just enrolled in a study on new neuroendocrine tumors and hopes the information gained will be able to help people in the future. That is great. That is awesome. Thank you. Thank you.
Yeah, that is a great comment, and I really thank you for that, because really you have to think of it that the only way we can move this field forward is for patients to participate in clinical trials. That's really the only way we can prove that the new therapy is better and possibly, hopefully, safer than the previous therapy. So that's how we have to move the field forward. We could never do this without you.
Absolutely. Okay, so we have another one here. Is there any research on how high chromogranin A needs to be before it would show up on a scan?
Great question. And so chromogranin is a challenging test. So keep in mind that chromogranin is elevated in a lot of other conditions, especially patients on these acid-lowering drugs like Prilosec or Protonix or acid tax. So I've seen chromogranin as high as 5 or 10,000 in those patients. Patients with chronic inflammation of the stomach have high chromogranin. Chromogranin is not a very reliable test to diagnose neuroendocrine tumors, and we actually really discourage the use of chromogranin to diagnose someone with neuroendocrine tumors. But I will say this though, that within individual patients, chromogranin can sometimes correlate really well with the tumor activity. So not perfect. So in some patients, the chromogranin increase may actually go hand in hand with worsening on the scans. So sometimes just measuring the chromogranin a little bit more frequently than you actually do the scans can give you an idea. So let's say if the chromogranin is not really moving, then in some patients, there is a good chance that tumors are not growing. But it's not a perfect association. Never, ever trust chromogranin alone. It's a nice test in some patients to do along with imaging, but we can't trust it alone.
Okay. Another one. Is PRRT considered at all an option for NEC/poorly differentiated when there are receptors present on a dotatate PET?
Really, really good question. And right now, the short answer is no. And we've known from studies done in Europe that even if you have neuroendocrine carcinomas that do have somatostatin receptors, and about half of them do, treating with PRRT does not seem to control them. On average, controls them for about 2 to 3 months. So meaning that they can get 2 treatments and then the tumors are growing in half or more. So that may change once we get smarter about adding other drugs to the PRRT as well. I could think, and there are some concepts going on looking at the addition of immunotherapy to PRRT and to targeted therapy to PRRT. So I think we're going to see better treatments for neuroendocrine carcinomas or NECs possibly with PRRT, but almost certainly in combination with other drugs. So right now, outside of a clinical trial, really no role.
Okay. So I have kind of like a two-parter here. The question in here says, can you explain the different situations that dictate use of lanreotide versus the use of octreotide? And also, how do you determine a treatment plan?
Yeah, so great. So octreotide and lanreotides are both what's called somatostatin analogs. And I think these are equally effective drugs. So they, in terms of if you get them where they need to go, the drugs work the same. The problem is that octreotide has to be injected deep into the muscles in the buttock called the gluteal muscles. And depending on our body composition, some people just have a little more padding in the back, and it's just harder to get the injection into the muscle where it needs to go. Also, as always is the case, is that whoever is injecting, people have different sort of just some people are just better than others in injecting. And it's been shown in studies in the past that up to 50% of injections that should go into muscle never make it into the muscle. So, and there were studies from Ireland many years ago, another one from Texas. And and I see this all the time when I look at the scans, that I see the drug and the fat in the buttocks and not in the muscle. So if there's any question about the sort of experience of the person injecting, I think lanreotide is a better choice because it goes under the skin. So if it's a leaner person with larger muscles in the back and a good skilled nurse injecting, I think octreotide is perfectly fine. So those are the things I look at. I think lanreotide is just an easier injection.
Okay. We were just asked do you think anytime soon that insurance companies will be approved to do a second round of Lutathera?
Great question. So, so we are getting this approved for some patients. Right now, I'm fighting with one insurance company. They just will not approve a second course of Lutathera, and others have, but some don't. And there is now a study called Net Retreat. So that's looking at retreatment with Lutathera. So these are patients who've had 4 courses of Lutathera, and now the tumors are growing. And typically, we don't want to see growth within 12 months of the last Lutathera dose. We're not sure if the repeating Lutathera will help in that situation if the tumors are growing within 12 months of the last treatment. So this study will hopefully help. And then a lot of patients are now being considered for another study of actinium-225 alpha particle therapy. So this is the ACTION-1 study that just is opening across multiple locations in the US now. So this is for patients who have previously been receiving Lutathera for anywhere from 2 to 4 treatments, now have tumor growth more than they cannot have had tumor growth within 6 months of the last Lutathera dose. But if it's beyond 6 months and now the tumors are growing, the patients on the ACTION-1 study will get actinium-225 versus physician's choice of 4 options. And if they get randomized to one of the 4 options and not to the alpha particle PRT, and then the tumors grow, then they can switch over to the alpha particle therapy through a mechanism called crossover. So I'd say we don't know yet when insurance companies will approve this, but I think right now, if there is tumor growth after previous PRT, by all means check to see if one of these trials is open near you, either the NET retreat with repeating Lutathera or ACTION-1 with actinium-225 alpha particle PRT.
Okay. We have a few questions in here. What is the NET test? What is its significance? How often should it be run? And also, what is its status within the NET community?
Yeah, so good question. So NET test is I wouldn't call it a novel biomarker anymore because it's been around for probably close to 10 years. So the NET test is a test that looks at the products of 51 or 52 neuroendocrine tumor related genes in the tumor. So we have ways of measuring that in the blood. So the thought is that when you have a neuroendocrine tumor, the tumors will release these products of the genes into the bloodstream, where we can actually detect them with really sophisticated methods. And that's what's done at the RAN laboratories in Connecticut. So the test is definitely better than chromogranin. But then I will say chromogranin is not a good test. So the fact that the test is better than chromogranin doesn't automatically mean it's a good test. It just means it's better than chromogranin. And so the NET test is not used much. So it's a better diagnostic test, but I have had a lot of patients with suspicious symptoms with diarrhea and things like that who've had a positive NET test, and we have not found a neuroendocrine tumor. Even years later, we have not found a neuroendocrine tumor. So then I'm questioning, is it really that specific? There are some really intriguing data on using the NET test following surgery. So meaning that if you have seemingly complete surgery for a localized neuron tumor and your NET test is high, then your risk of tumors coming back in the next 2 to 3 years, the risk is much higher than if the NET test is normal after surgery. So we've been using this now for 2 or 3 years, and I will have to say I'm a little disappointed in it. So most patients will not have a normal NET test after surgery. They will be sort of in the low abnormal range. And some of them have been following for 2+ years now, and I don't see any tumors coming back. So I'm not sure how good it is, but maybe I just haven't been following them for a long enough time. The other thing that I've been a little bit worried about, there have been now a few patients where we did the NET test before surgery. We knew there was a neuroendocrine tumor. We did the NET test before surgery. The NET test was negative. They went to surgery. A neuroendocrine tumor came out. So the NET test missed that tumor. These are not many cases, but they are enough for me to just be a little bit worried. So here's how I use the NET test. If for all of my patients who have had complete surgery, I offer them the NET test. We talk about it and say the data are really strongly suggestive of this predicting tumors coming back after surgery. Are you interested in me using the NET test to follow up? One of the problems with the NET test is that as of this year, patients are paying, I think, $200 for the test. And if the test is not clearly changing what we do, it's hard to justify that cost, even though it's not a very expensive test. So I use it selectively. I almost never use it for patients with advanced or metastatic neurotumors because I rely on imaging. I do not think the NET test changes anything there. So it's a test that's sort of finding its role in the neuroendocrine tumor community, and I just think we need better studies. There have been a lot of studies on the NET test, but we just need better studies.
Okay. Are you seeing an uptick in NET diagnosis in the recent years? And if you have, why do you think that is? And are you seeing patients that are being diagnosed earlier in the disease as opposed to later?
Excellent question. So yeah, absolutely. So we're seeing a lot of increase in in new diagnosis, and I can tell you which are the tumors we're seeing the greatest increase in: pancreatic, rectal, stomach, and lung. And I can tell you that the increase in the rectal neuron tumors, I think, is largely explained by screening colonoscopies. So Americans are actually getting really good at getting their screening colonoscopies. We can do better. So I'm going to put a plug in for that. So, but if you have a screening colonoscopy, well, you may have a totally clean colon, but there's that little polyp in the rectum that we remove, and it's a 4 millimeter neuron tumor. So we are picking these tumors up just because people get in for screening colonoscopy. Same thing with the pancreatic tumors. Someone has like a kidney stone, goes into the emergency room, gets a CT, or someone slips on the ice and falls and has a abdominal pain after the fall, goes to the emergency room, has a CT, and we find neuron tumors. These are called incidental findings. So I think the increase in new diagnoses of neuron tumors is largely explained by incidental findings. So patients are getting scans or endoscopies for something that's totally unrelated, and the neuron tumors found. So that is actually the explanation for us finding the tumors at much earlier stages now. We looked at the pancreatic neuron tumors just 2 years ago and looked at the large database in the US. And we see that there's a threefold increase in new pancreatic neuron tumors in the US in the last 15, 20 years. And almost all of that increase is explained by early stage tumors found incidentally on scans done for another reason.
All right. I have another question here. Is it important to see a NET specialist if you are currently NED? Um,
That's a, that's a very interesting question. So probably it's not as important as if as seeing a NET specialist if you have active tumor. I think probably the most important thing for someone who is NED, meaning with no evidence of disease following surgery, is really just for the treating or following physician or clinician, be it an oncologist or an endocrinologist or a gastroenterologist, just to follow the available guidelines. Just make sure you do the appropriate tests at the appropriate times. So you get your scans, you get your endoscopies when recommended. And there are multiple different guidelines. So the NCCN has guidelines, the North American Neurotumor Society has guidelines, the ENETS, the European Neurotumor Society, has really outstanding guidelines. And they pump those guidelines out much faster than any of the other organizations, and definitely worth checking out. So it's what I would say: if you're not being followed by a NET specialist, it's a fair question for your doctor or for your provider to say, are you aware of the guidelines that are out there regarding surveillance? Just to make sure that they are following them.
yeah, just a real quick follow up to that. The reason why it was asked is because this person tried to get into Mayo, but they said they wouldn't pass them through because of no evidence of disease.
That is a little unusual. So typically, so I will tell you at the NET clinic at Mayo, if you don't have a proven neuron tumor either currently or in the past, it's hard to get into the NET clinic because we unfortunately we just don't have the capacity to see patients for like diagnostic purposes. Those all go to gastroenterology. And but if you've had a neuron tumor in the past and you don't have now it's been removed and you want to come in for another opinion, that should be there might be a delay, maybe a month or two to get in, but we should be able to see you. So I think it's I'm happy to reach out to our schedulers, and I'm not sure what's going on there. If there's a past history of a neuron tumor within the last few years, we're typically happy to see people.
Okay, good to know. Oh, we have a question here from the comments. Saeed, is endoscopy included in surveillance after EMR?
Great question. Let's say EMR would be endoscopic mucosal resection. So this is one of those endoscopic resection procedures. This is most commonly used for patients with stomach, duodenal, and rectal neuron tumor. So you have a small tumor in the stomach, it's removed with the endoscopy, and yes, you should have an endoscopy follow-up. There were just this week, there was an interesting paper that was just published and from France. So they looked at patients who had rectal neuron tumors, and they looked at the patients who had what's called an incomplete resection. So they had the rectal neuron tumor, the endoscopist removed the tumor, the margins were positive, seemingly leaving some tumors behind. So they went back in and did a more thorough endoscopic resection. And 43% of the patients where they resected what's called the scar, where the tumor used to be, 43% of them still had neuron tumor there. And when they did the second surgery, almost 100% were NED with no evidence of disease after that. So yes, you have, if there's an incomplete resection, you absolutely have to follow that up. If it's a complete resection, let's say from the duodenum or the stomach, or a stomach or a duodenal neuron tumor, and it's been removed endoscopically, typically we want endoscopic surveillance. And depending on the tumor size and the tumor grade, that could be at 6 months or 12 months or 24 months. It depends on the size of the tumor and the grade of the tumor.
Great.
And I see that there is a duodenal tumor 1 centimeter with a clean margin. We would typically want to go in and sometime after the first surgeries, like 6 to 12 months after that. That would probably be my recommendation.
Great. We have Dr. Thomas here. How do you submit for second opinion follow-up after surgery for an accurate guideline follow-up? Is there a lot of difficulty at the grassroots level? Email, facsimile number, phone number? Thank you.
Yeah, it's a good question. So I ideally think after a resection for a neuroendocrine tumor, for me that's a good use of a neuroendocrine specialist. So we may I think it's a good reason to see a NET specialist just to get a like a surveillance plan. So when I see patients like that, I will tell them, well, according to the currently published guidelines, this is the follow-up that's appropriate for this kind of a tumor. And then I say, I can do this here at Mayo, but if you live 4 states away and you have a really good local medical center, I can also just put it all in my note and say, according to the 2023 guidelines, this is how things should be. I don't think the surveillance guidelines change that quickly, that critically, that people need to keep coming back to a NET center, but coming at least for one visit is a good idea. And how do we get people in there? So I think it's really at the grassroots level, just get it out to the NET community that yes, it's probably a good idea to reach out to a neuroendocrine tumor center near you, and for a post-surgical follow-up visit, just to formulate a future surveillance plan. So, but the problem is always just getting people in. So as you know, there's a lot of people with NETs in the US who get therapy and they're really never aware of the fact that their NET specialists exist in most states of the US.
Great.
And it may we'll also say whoever did this may also actually have such experience with NETs that you may not really need it.
Okay. Perfect. I have a question here from the text. What is Cognet? I can't find any information.
Oh, yeah, I am not sure if I really Cognet. So not ringing a bell for me.
Okay. Let's see. Tom Wilson in the comments here. How prevalent is NETs within families, and if someone wanted to check other family members, what tests should they consider?
Oh, that is a really good question. So let's address this sort of looking at the really common neuron tumors. So for pancreatic neuron tumors, probably up to 10% of them run in families, almost always with an MEN1, multiple endocrine neoplasia type 1. So these are patients who have pancreatic neuron tumors, parathyroid tumors with high calcium, and occasionally benign pituitary tumors. And so and they almost always have high calcium before the age of 30, that needs genetic testing, that needs screening of relatives. So those, if you have MEN1, it's a what's called autosomal dominant. So half of your children are expected to have it. So this really heavily runs in families. There are multiple members, but that's a tiny minority of what we do. So for the small bowel nets, we know, and we've known this for probably 2 or 3 decades from large studies in Sweden, that if you have a small bowel net, the chances of your children getting it is probably anywhere from 5 to 10 times what we see in the average population. But the key number here is that the chances in the average population of getting a net are so small that even if you multiply that by 5 or 10, it's still a tiny number, and we don't really have a good test. So if there is not an MEN1 or a von Hippel-Lindau syndrome or something like that, we typically do not recommend any screening of relatives or any genetic testing, because we don't really know what genes are implicated. But here's an example of how important it is to follow the literature. So every week I get a notification of all of the neuroendocrine tumor papers published the week prior. So this Friday, yesterday, so in my inbox was my list of the weekly report, and there is a paper from a study team in Finland that's looking at hundreds of patients with small bowel neuroendocrine tumors. And they found that previously, and they compared the genetics of those to the genetics of just normal people in the Finnish population, and they described 2 or 3 new genes that no one has really heard of. So these are the things that we might actually have to test for in the future. So this is obviously very, very early. This would totally have flown below my radar if it wasn't for the fact I'm getting these alerts. So that might actually be, and I think 10, 15 years from now, we'll know so much more about these genetic abnormalities that we can actually test, but we just don't have that information yet. So yeah, it's an increased risk in the families, but if you don't have a known syndrome, probably not much we can do about it.
Okay. We're going to start winding down a little bit. So if anybody has any last minute questions, please make sure you're sending them in. What is the distinction between functional and non-functional tumors?
Oh, that's a classic question. And actually, it's very important. And so according to the NANETS definition, which is consistent with most other definitions, a functional neuroendocrine tumor is a tumor that produces a hormone or a chemical that results in symptoms directly related to that chemical. So a non-functional tumor has no such symptoms. So you can have a functional tumor, let's say a pancreatic neuroendocrine tumor that produces gastrin, is functional if it causes symptoms of gastrin production, like diarrhea or heartburn and things like that. Sometimes you can have neuroendocrine tumors that produce a little bit of a hormone, this hormone or that hormone, but it doesn't cause any problems, and we call them non-functional. You have to have the symptoms like the diarrhea or flushing with small bowel neuroendocrine tumors or some of the pancreatic neuroendocrine tumor symptoms. You have to have the symptoms from the hormone for it to be called functional.
Okay. Dr. Thomas wants to know how to get on that email alert list.
So you actually created yourself. So I'm not sure if you're familiar. If those of you who are familiar with the National Library of Medicine or PubMed. So this is a service run by the National Institute of Health. So this is sort of the Google search of medical literature. So called PubMed.com, and so you could go in there and you create an account. You can just use your Google account to create your own account, and then you can create a search for yourself. So I have a lot of different searches. So you just say neuroendocrine tumors and send me, like every Friday morning, send me an alert of what was published on PubMed in the last 7 days. So everyone is interested in different things. Some of my friends, they only want to know about the biology of tumor, and they only get those emails. So you just create those search strings and just set it up for automated. It's almost like a subscription service. You create it on your own.
Perfect. Julie DeClerc is very interested in that SBNet study in Finland. So thank you for sharing that.
It is. When we're done with this, I'm actually going to read the paper. I just downloaded the paper yesterday, so I just looked at the abstract and said, "Wow, man, that's interesting."
It's good. It's great. Real quick, I did get a follow up here for Cognet. Composite ganglicytoma / neuroma neuroendocrine tumor.
That is honestly, I when it comes to nets, I don't often get stumped, but I am stumped. So it's I honestly would have to look this up.
Yeah,
I have
they're
heard
saying
ganglioneuromas. I've heard, but I've never heard. I wonder if it's some sort of like composite tumor that has elements of both. This is something I would have to look up.
Okay, and I know that we were talking about being involved in clinical trials and stuff like that. Is there anything that you see that are what are some of the exciting and up and coming diagnostic and treatment tools for neck cancer that you're seeing?
Yes. So if we start with some like the testing, I think there's a lot of things going on in these like genetic testing, looking at risk factors, like that study from Finland. There's a really cool data looking at the like almost like a version of the NET test called PPQ or PRRT predictive quotient. So when this test is done before PRRT, it actually may, seemingly with great accuracy, predict the patients who get much more benefit out of PRRT versus those who get less benefit. So we might sort of start looking at that and see who should get PRRT, who shouldn't. So this obviously needs to be tested a little bit better, but that's really exciting. So a lot of other tests coming that are not nearly as far along as the NET test or chromogranin in terms of how well they have been studied. As for treatment, so I think a lot of the buzz is now around alpha particle therapy, actinium-225 and lead-212. So the actinium study is up and running. That's action 1. There's a number of lead studies coming with the lead-212, one through I think it's Excel Diagnostics in Houston. They have some really cool early data. And then another company called Perspective Therapeutics is hopefully going to launch a trial soon. And others are on their way. So I think that's really exciting. So another really exciting possibility is the combination of PRRT with targeted therapy and immunotherapy. That is not ready for prime time yet. It just needs to be properly studied. And then the targeted therapy. So some of you may have heard the news on this cabozantinib study, the CABINET. So the CABINET was a large trial going on multiple different states and centers in the US, looking at cabozantinib, which is what's called a kinase inhibitor, compared to placebo in patients with neuron tumors that had grown on previous therapy. So this study was supposed to go probably for another year or two, was closed last month fairly suddenly, because apparently the people who look at the data said there is such strong evidence that the drug may actually be better than placebo. We can't really continue the study. So we haven't really seen the numbers yet, but it seems like we might have an exciting new option on the way. So, and then all of these other drugs that we don't really know about yet. So the better understanding of the biology of the drugs will lead to better treatments. And probably the best example of that is for the really rare pancreatic neuron tumors in patients with what's called von Hippel-Lindau disease. So it's a genetic condition, runs in families. These patients get all sorts of tumors, including pancreatic neuron tumors. And there is now a drug called belzutifan that works beautifully. More than 9 out of 10 of pancreatic neuron tumor patients respond to this if they have that genetic mutation. So I think as we understand the tumors better, we're going to be much smarter at treating them. So I can't even think of all of the drugs or targets out there that we are just about to discover, I think.
Okay. I got a last question here. How do you tell a tumor, which is confirmed by pathology, is in the primary location?
That is, oh my goodness, I wish I knew the answer to that. So this is actually really interesting. So someone comes with a metastatic, let's say a metastatic tumor, we do a biopsy and we're trying to find the primary, we can't see it, it's nowhere on the scans. So there are some ways we can do what's called immunohistochemical staining, stain it for different things or like certain things, stain, like there's a test called CTX2, another one called SAPI2, that's almost always like small bowel. We have some stains for the lung tumors, but none of them are perfect. They're like 80, 70, 80% accurate. So that's not good enough. So we're looking now at genetic testing. So we're looking at like a whole series of genetic mutations, and we can put this into what's called like machine learning or artificial intelligence, and it will sort of spin the numbers and guess based on the presence of these mutations and absence of these mutations. There's 95% chance of this being lung. So we're starting to use that a lot more. But sometimes we just truly don't know. So I saw a patient this week, and I just don't know. So then we just have to treat with like lanreotide or octreotide if the receptors are present, or if not, with something else. So a lot of times we just don't know.
All right. Well, Dr. Thor, thank you so much for spending all this time with us and for answering everybody's questions. It was awesome having you. And
anytime, always glad to be here. Just call me up. I'm always happy to show up.
Perfect. Guys, I want to remind everybody again, October and November, we have really, really, really awesome months ahead of us. We have our virtual walk, which you can do anywhere. Our in person in Charlotte, North Carolina on November 4th. Please make sure you're registering. You get this nice shirt here. Also, we have our Net Patient Conference in Miami, Florida. This October 14th, we've got Dr. Aman Chauhan, Dr. Lowell Anthony, Dr. Heidi Del Rivero, and a lot more. Great panels ahead of us. And don't forget also the 20th anniversary gala here in Long Island, New York, in Bethpage. If you'd like to be a part of any of these things, please go to netcancerawareness.org. Also, you can catch us on social media at NetCancerAware. We're going to be doing these live streams more often. Once again, we're going to be moving the day. It is going to be on Wednesdays, so keep an eye out on that. We'll let everybody know all about it as we get closer to the event. And once again, thank you for spending your Saturday. Have a great weekend, everybody.
Thank you very much.